Back here doing another Glaucoma Australia Facebook Live. And I'm assuming you can all hear me. It's been a little while since our last show, but started with a big topic, didn't we? Started with COVID-19, the biggest pandemic of the our era, and now we're moving to something even bigger: cannabinoids or medical marijuana and glaucoma care. So we've already had a few questions come in on this topic. Here we go. I can see some thumbs up, so I assume someone's out there listening. So we're going to discuss this today. Happy to answer any questions you have. Of course, I have my lovely Sapna from Glaucoma Australia who is texting me through questions as they arrive. I'm trying to manage a couple of screens here, so I'll do my best. Feel free to ask what you wish. I'm going to sort of run through an overview of this topic. The goal is for me is just to provide a balanced viewpoint here. I don't, see any need to stigmatize this in any way. Just look at purely at the factual evidence surrounding this. What I will start with by saying is that we don't have a huge amount of data on this topic. Obviously, it's of great interest to many people. It's a source of hope for some, and but I don't have. There is no one in the world who is going to be able to stand up and provide a absolute definitive answer on this topic because we just don't have the publications. What I can provide is at least a summary of what is available and some overview of the rationale that we have accumulated to date for or against this topic, just so that you are better informed in terms of what the current role may be and what the future could hold in this area. So I'm going to start by good, you can all hear me. So I'm going to start just providing an overview of cannabis, just so we're all on the same starting point. This is not a marijuana podcast or marijuana Facebook Live. You'll find more detailed information elsewhere, but at least let's all start on the same point. So, cannabis is a species of plant, and it's a genus of species of plant. The three main plants or varietals that we have are Cannabis sativa, Cannabis indica, and Cannabis ruderalis. So, Cannabis sativa is the one that's best known. That was originally used for hemp. So Cannabis sativa is a very tall plant. It has fibrous structures within it, which made it very good for sales and genes. The first pair of Levi jeans were made with Cannabis sativa. And so hemp is basically the fibrous properties of Cannabis sativa when it's cultivated to have a very low THC content. So hemp can still be manufactured, obviously. Has to have a THC content less than 0.3%. Whereas cannabis that's been cultivated for psychoactive properties these days will have a THC content more like 10 to 20%. So it gives you an idea of the way these plants can be cultivated over time to have unique psychoactive properties. Now, in terms of Cannabis indica, just a sidestep, is the other probably better known species of cannabis plants. I understand it to be more sedating in terms of its cannabinoid profile. Cannabis ruderalis is a small shrubby plant that is mainly used for growing hybrids. So, Cannabis sativa, a very large plant, difficult to grow. In a indoor environment, let's just say that, and has a fairly a difficult flowering cycle. So these plants are now combined, and we don't really see too many of these being used, in my understanding, as a pure species. Most cannabis plants that we have are hybrids that use different forms of the different plants. So, okay, so why are these plants important? They're obviously important because they contain cannabinoids. So cannabinoids are a family of molecules that all share a similar structure. We know of around 66 different types of cannabinoids. By far the most commonly known is delta-9 THC, which is the main cannabinoid present in Cannabis sativa. But the others that are well known are CBD and CBN. However, if you look at the medical literature, the vast majority of studies come from studies looking at delta-9 THC. We don't have nearly as much scientific evidence about the effects on the body of CBD and CBN or the other 63 cannabinoids. But just talking about delta-9 THC, because that's what we'll be talking about for the majority of this episode. Originally, like I said, hemp is less than 0.3%. The studies back in the 1970s, 1980s, which is where a lot of the actual data still comes from, those cannabis plants would have a THC content around 0.9%. Ranging up to around 3% in some more recent studies, and the more recent cultivars are up around 10% or 20%. So These plants are being cultivated for higher delta 9 THC content over time. Now, the cannabinoids are important because obviously we have receptors for them in the body. There's two cannabinoid receptors, CB1 and CB2. These are present throughout the body, and they basically regulate the release of neurotransmitters. So these receptors are on throughout our nervous system, and they can have differing effects on different organs or different nerves in terms of increasing or decreasing the amount that the nerves will communicate with one another on for their neurotransmitter release. Getting some comments through already, I think. Anyway, so we also have endocannabinoids. So we actually already produce cannabinoids within our body, and it makes sense. We have the receptor, so of course we're likely to produce these molecules ourselves. I guess for just to summarize the background of cannabinoids is that it's important to note that these plants are very non-standardized. Like I said, we have 66 cannabinoids that we know of. Different species of plants will have different profiles of their cannabinoids. It will also depend on how the plant is grown, which part of the plant is harvested, and so you'll have quite a different cannabinoid profile depending on how the product is obtained. So it's a very non-standardized product whenever you talk about cannabis plants, which is why we really need to be shifting away from plant-derived sources of these and more towards synthetics, where it can be much more tightly controlled. The other thing is to say that, of course, these plants contain a cocktail of other molecules, proteins, carbohydrates, other structures as well. And so when they're taken, it's not just the cannabinoids you're exposed to, but everything else in the plant as well. Most of the research has been around delta 9 THC, but these are like complex products with a huge constellation of molecules that they contain. Now, let's move towards cannabis and eye pressure. So this came around in 1971 from a study by Hepler and Kemp out of Los Angeles. So at this point, it wasn't really understood what the effect of cannabis was on the eye. So these investigators, they took 11 subjects, or a small sample. They did comprehensive eye exams before and then 1 hour after smoking 2 grams of cannabis containing 0.9% THC. So remember, 0.9% back in 1970. Today, products will contain 10 to 20%. So much higher content of THC in modern or products that are available today than what was studied when this was first looked at in 1971. These investigators didn't really know exactly what they were looking for. They're just looking to study what the effects on the eye. So a full comprehensive exam. The big finding that came out of this, of course, is that the eye pressure in these individuals did lower. So the drop was actually, I think, fairly impressive in that these individuals did not have particularly high pressures. They're normal, healthy individuals in their 20s, most of them 20 to 45. And so that we're talking pressures here of 15, 16, 17. However, an hour after inhaling the cannabis, the pressure had dropped quite remarkably in many of these people. And so we came back with a pressure reduction of around 30%, some of them up to 45%. Now, I know there are other products in the market, other glaucoma medications that can achieve sort of 30% pressure reduction. That's not unheard of. I think what's perhaps a little bit more noteworthy is that these patients did not have particularly high pressures. So it's easier to demonstrate a large pressure reduction when you have a higher starting pressure. So it's far easier to demonstrate magnitude of effect if the pressure is sort of in the mid to high 20s. And if you look at most of the studies of pharmaceutical or even surgical agents in glaucoma, most of them will try to enroll patients with higher pressures because it's easier for the product to show a dramatic benefit. Whereas this study was more noteworthy because the people had fairly unremarkable pressures and they came back with a dramatic drop after just an hour. So this was actually published as a case report just to get this message to market because it was unexpected and it was new. Now they were in healthy eyes. These patients did not have glaucoma. So obviously what's of importance to us is do those results translate to individuals with glaucoma? And yes, to an extent they do. If we look at individuals with glaucoma, we don't have a huge number of patients to pull data from in here, but we're looking at overall, around a 30% pressure reduction in most individuals. Now, of course, we're dealing with biology here, so there are some people who might get a slightly greater pressure reduction, other people will not get any pressure reduction. But overall, around a 30% pressure reduction. The onset is peaking at around 60 minutes, and the duration of the pressure reduction is around 3 to 4 hours. And I'll come back to that. 3 to 4 hours is fairly short, but I'll come to discuss this in a moment. So, how do the cannabinoids, how does delta 9 THC, or how does the cannabinoids lower eye pressure? What's the mechanism? So, I've mentioned initially that these plants are very complex, contain a huge number of molecules, including a different profile of cannabinoids. Most evidence indicates fairly clearly that it's delta 9 THC that is acting on CB1 receptors on the eye. So it is not an effect of the other cannabinoids as far as we understand. In fact, CBD, another commonly accessible cannabinoid, will actually have some antagonistic effects on eye pressure. So that means that if you had a product that had CBD and THC, that the CBD will actually start to impair the beneficial pressure lowering effect of the THC. So that's just something to keep in mind, again, when we're talking about non-standardized products that contain a whole profile of different things. Now, it's working on the CB1 receptor on the eye, and it's a local effect. And I just emphasize that because some medications can act systemically. They can act on pathways in the brain that can then have downstream effects on the eye. And that was certainly queried with cannabis because there are a lot of receptors in the brain. But if you have cannabis applied locally to one eye as a drop form, okay, THC is a drop form to one eye, you'll get a greater pressure reduction in that eye than the fellow eye. If in animal studies, if they infuse the molecules into the cerebrospinal fluid of the brain, so not actually exposing the eye directly to the molecule, but actually just bathing the brain in the molecule, you will not see a dramatic pressure reduction. So it is truly a local eye effect of the molecules binding to their receptors on the eye. And this is another important point we'll come to later. In terms of how pressure reduction is achieved, this is a combination. So it's both an increase in outflow of the drainage system of the eye, but it's also a decrease in fluid production of the eye. Again, we don't have really convincing, conclusive data to tease out how much of those relative two pathways it is. It appears to be more an increase in aqueous outflow and fluid drainage of the eye, with also an additional benefit of some reduced aqueous humor production, reduced fluid production by the eye. Now, there are several other commonly available glaucoma medications that are similar, both increasing outflow, reducing production. This is 2 points here. One is that we're using a different family of receptors in this case, which is a benefit of the cannabis pathway, because we're by exploiting a different family of receptors, we can further enhance pathways, even if a patient is already has saturated or has full activity of pathways used by other medications. So that means that this cannabinoids can be more synergistic, or there's a potential role of them being synergistic with other glaucoma medications because they are enhancing aqueous outflow, but using a different family of receptors in order to do that. I think it is, just an aside, it's promising. I like the fact that it enhances outflow, because that's always, to me, I mean, the problem in glaucoma is not that the eye produces too much fluid. That is not the problem. The problem is that the eye does not drain fluid normally, and that elevates the intraocular pressure. So the best approach is always to enhance aqueous outflow, because that's the primary problem in glaucoma. The other benefit of that is it helps to blunt pressure fluctuations. So when I analyze or looking at different treatment approaches, I would always prefer to choose a medication that's going to improve my outflow rather than a medication that's going to turn the tap down and produce less fluid. Because if I turn the tap down, A, I'm not targeting the primary problem in glaucoma, but B, I may lower the overall pressure, but the pressure fluctuation is less blunted, i.e. someone can have an overall lowering but still have a lot of pressure fluctuations. As soon as you enhance the outflow system, you lower the overall pressure, and you also help to blunt those pressure fluctuations that occur during the day. So I do like the fact that at least this cannabinoid pathway is enhancing aqueous outflow, and therefore is lowering pressure, but in a way that is targeted to the problem of glaucoma. and is also, in theory at least, going to help to blunt pressure fluctuations more than if the pathway was just turning the tap down inside the eye. Okay, so that's kind of a bit of an introduction. It sounds very promising. Let me just talk about some of the problems of using this cannabinoid pathway in its current form for glaucoma care. So I mentioned already the duration of action, peaking at around 60 minutes, with a duration of around 3 to 4 hours of pressure lowering before it returns, essentially back to baseline or back to normal. Now, that's reasonable. However, in glaucoma, we really need stable pressure control, and we need stable pressure control continuously throughout 24 hours and for years and years of life. So having a medication that will only lower pressure for 3 to 4 hours means that the dosing interval would need to be very frequent. Otherwise, you're going to see large fluctuations in pressure as the medication acts and then wears off. And so, it's been calculated. If you were going to use cannabis in order to achieve stable pressure control, you would need to be taking, if you're using the inhaled route, you would need to be having sort of 8 to 10 doses in a day. And by calculations, that would cost a significant amount of money. So 8 to 10, it's been calculated, 8 to 10 marijuana cigarettes a day. If you are someone who gets a significant pressure reduction, 8 to 10 marijuana cigarettes a day, in theory, could give you stable pressure control. That is a cost, when it's been costed in the US, of about $2,000 per month. So we start to see why this hasn't really taken off and some of the limitations here. Now, I do think that 3 to 4 hours is still potentially meaningful in terms of a pressure reduction. There are many instances when I would like to have a medication that is fairly potent at bringing the pressure down, that I can add on top of existing medications, so synergistic to existing medications that can lower the pressure, even if it's just for 3 or 4 hours. But those types of medications are more useful to me in a clinic setting, perhaps at the time of procedures, when patients might have short-term pressure spikes, to lower the pressure just for that brief period. So I still see a therapeutic role here, even if the longest duration we can get out of this pathway is only 3 to 4 hours. But for long-term stable glaucoma care, this is really frequent dosing that's required, and so that's a major limitation at this point. Okay, another significant limitation is the concept of tolerance. So the medical name for tolerance, of drug tolerance, is tachyphylaxis, which means that as you have repeated exposure to the medication over time, the therapeutic benefits start to diminish. And this can be a product of multiple reasons, but usually it's because your body will downregulate the receptors to that particular agent, and so your body will stop responding in the same dramatic effects with each subsequent dose. And so tolerance occurs with many medications. The tolerance with cannabis, in terms of its pressure lowering effect, is a little bit controversial. It's certainly suspected. It's not known for sure. It's not proven. Let me just explain this. There have been some animal studies that have found that repeated exposures to cannabis have not demonstrated a tachyphylaxis. So the animals have continued to experience a significant pressure lowering from repeated exposures without any clear demonstration of tolerance over time. So that's favorable. There has been a study that looked at cannabis exposure in individuals who were exposed to cannabis regularly and individuals who had never been exposed to cannabis, and it looked at their pressure lowering effect in those two groups. And in those two groups, they also found that there was no clear distinction in terms of the magnitude of pressure lowering between those who used cannabis regularly and those who had never used cannabis. So that is also favorable in indicating that even if you are a regular user, perhaps the pressure lowering effect will not develop tolerance over time. However, in 2002, there was a study it was a small study. It was 9 end-stage glaucoma patients, and basically these were given THC capsules to inhale every 4 hours. Of those, the majority of the individuals did have a pressure reduction. However, over the following months, most of them, 7 of the 9, lost that beneficial pressure lowering effect, and it was assumed due to tolerance. And within 9 months, all of those individuals who were provided with this free medication electively decided to withdraw from the study due to either no longer seeing the beneficial effects that they wanted or developing other side effects, systemic side effects, effects on the body from having regular THC exposure. So that's a little more concerning. It's a small study, but I'm just sharing with you the conflicting evidence about tolerance and whether that's going to be something that's long-term going to limit this pathway. Now, obviously, I don't need to mention here, but there are obviously psychoactive effects of THC. Now, if you're using THC for glaucoma care, then I would certainly say that the psychoactive effects are an unwanted side effect, I would imagine. And, there's question about whether you will develop tolerance to these. There is a level of tolerance that will be developed with repeat exposure in terms of how the medication affects your cognitive ability. Certainly many instances of people who are regular users of these of cannabinoids and can appear to function at quite a high level. However, I don't think we should overemphasize that development of tolerance. There's certainly going to be a period of time when it would have you would think, quite a significant impact on your ability to function at your previous levels. So it's going to take quite a while before you do develop that tolerance. And tolerance will never be complete. You will always still have some effects of the medication in terms of on your cognitive function. And the obvious answer to that is that if tolerance was complete, then no one would continue using marijuana. If the effects completely wore off with repeat exposures, then why would people continue to use it? It obviously has ongoing effect on those even who use it regularly, and that's sort of why they would justify continuing to use it, because they like those effects. So tolerance, neurotolerance will develop, but it will be partial, and there would be that period of time when the systemic effects on the body and the mind could be quite substantial before those side effects started to downregulate. Okay, so what is the way forward from here? I've shared with you some of the evidence of beneficial effects on pressure and then some of the limitations. In terms of the way forward, so I do think there is potential in this space. One of the big considerations going forward is what route of administration would you choose. So obviously, if you have this systemically, if you take it ingested or inhaled or any other route where your whole body is exposed, you're going to have those side effects on the body, like I mentioned, including the psychoactive side effects. If you inhale it, you also have the risks of inhaling smoke. And so those are the same risks of cigarette smoking and chronic obstructive airway disease and other problems from that. So smoking is obviously not going to be advised at all here. Of course, people are now vaporizing medications. I don't think there's any that I'm aware of, good data about that in glaucoma, but I guess it's a theoretical way to have the medication inhaled, but with less risk to the lungs of inhaling smoke of an organic product. The oral route is problematic because the absorption is so variable. So it will depend quite significantly on what's already in your gastrointestinal tract. And so oral ingestion doesn't really make a lot of sense. You're going to get the systemic side effects. You are going to have a variable dose based on what else you've ingested, that day. So what we really want here, what the route going forward, if we can find one, is going to be an eye drop. So like I said that THC is lowering pressure by binding to CB1 receptors on the eye. And so if we can just activate those receptors, but without exposing the rest of the body to the molecule in any great way, then that's fantastic. We should get the pressure lowering effect that we need, but without that constellation of unwanted side effects. So the thing that has slowed progress in this field so far is the fact that the cannabinoids are very lipophilic, which means they're hydrophobic. They repel from water. And obviously, if we administer an eye drop, the first thing that medication is going to strike is the tear film, which is basically water. So we need to repackage the molecule in a way that it can still mix with the tears and then reach the cornea or the front window of the eye and then be absorbed through the cornea. So this is actually not too difficult to do. There's in the last 10 years, there's been a number of medications in similar class as the cannabinoids that they have been able to repackage and allow to penetrate into the eye quite effectively. So that will be something that's here we are. I've just got a question that's coming through. Can you use? Okay. So the question is, can you use THC for a quick pressure lowering effect? For example, to lower eye pressure after events such as weightlifting. Okay. So yeah, in theory, if you were someone who does respond to the cannabinoid pathway, and I just say that because not everyone does demonstrate a pressure lowering effect. But if you are someone that does respond, then yes, by having a exposure to it, you would expect a short, relatively short duration of pressure lowering in the order of 3 to 4 hours from using it. There's a delay, obviously, like I said, of about 60 minutes before you'll get that pressure response. Maybe the small caveat here is for weightlifting, the pressure elevation during weightlifting is very, very short, like in the order of seconds to minutes. And it's mainly due to holding your breath during lifting the weight. So it's called a Valsalva maneuver, where you close your glottis, close your mouth, and you actually basically pushing your diaphragm down to give yourself a more rigid thorax so that you can actually lift the weight. So the Valsalva maneuver is problematic because it massively increases the pressure in the vessels in your thorax and abdomen, and that is transmitted to the eye as well, and that will briefly elevate the pressure. And so we now have these devices that can measure the pressure in real time, both contact lenses, or you can even use an eye care tonometer to measure the pressure. And studies in weightlifters show that they do get a spike in pressure during the lift and for a few minutes after the lift, perhaps. But it's really very transient. In fact, most of the spike is really just during the lift and for a matter of moments or seconds after the lift is completed. So I don't know. I don't. You would have potentially some blunting of effect, but I don't think it's going to be with the delay to action of the THC. I don't think it's going to be too dramatic. But yes, I do think that the role of this is going to be in short-term pressure control, and I guess weightlifting would be a potential example of short-term pressure rises that could be blunted with something like this. Okay, so we're talking about just coming back to the issue of roots. So we're using what I'm advocating here is going forward. This would be basically for an eye drop. If we could repackage these molecules into an eye drop, then now we have something that actually has some real potential to have a therapeutic role in medicine. I mentioned early on about how this is such an non-standardized product when you're talking about using a plant form of cannabis, and therefore the big move is going to be towards synthetics. So actually manufacturing these molecules in a laboratory rather than growing the plants and extracting from them. So in synthetics, there are synthetic cannabinoids that don't appear naturally, but can be made that have very potent binding to the CB1 receptor or CB2 receptor with little psychoactive effects. And so this has promise in medicine because you now have a way of exploiting the therapeutic effects or the therapeutic pathways for these molecules without the patient having to incur unwanted side effects on the mind and their cognition, etc. So an eye drop, ideally a synthetic, that has maximal pressure lowering for the longest duration of action and with the smallest potential for effects on the brain could have promise. And of course, when you have a synthetic, maybe there'll be a way to have a prolonged duration of action so we can push that out beyond the 3 to 4 hour window I was discussing. The final thing, obviously, is to understand tolerance. So this medication would always be restricted to very short-term pressure control, probably around procedures, if there is the development of tachyphylaxis or drug tolerance. So there's no point in even discussing this as a ongoing long-term glaucoma treatment plan if we are seeing that many patients have a loss of the beneficial effects over time. So this needs to be investigated further in glaucoma patients. Like I said, we have Very little studies on this, so it's difficult at this point to give any conclusive answers. Okay, let's talk about one other thing that gets mentioned around THC is whether there are other benefits, and that's neuroprotective benefits. So, neuroprotectants are medications or products or treatments that will potentiate the ability of your the nerves, so the retinal ganglion cells, the nerves that are damaged by glaucoma. A neuroprotectant will enhance their ability to survive stress. So in glaucoma, the main stress they're subject to is pressure inside the eye. Maybe there are also some stress from blood pressure or other parameters we can talk about on another show. And a neuroprotectant is basically making them more robust to withstand that stress. Even if the stress is not removed, even if we just ignore the pressure and let the pressure run, a neuroprotectant in theory would enhance that nerve's ability to withstand that stress. And so there's been some discussion about whether cannabinoids or THC is a neuroprotectant. Again, it's quite controversial. It's come about principally because it's been shown to reduce the release of glutamate. Glutamate is involved in process of cell degeneration when blood supply is scarce. We call that ischemia. And glutamate is important in cell degeneration from a number of toxic pathways that can ultimately lead to cell death. So by impairing glutamate, by slowing glutamate release, in theory, you're going to reduce the risk of cell decay. THC is also a free radical scavenger, and so it works like an antioxidant in that regards. And there is some evidence, of course, that it also increases blood flow. And by increasing blood flow, that could be advantageous in glaucoma because there is certainly a theory that some individuals, at least, their optic neuropathy or their damage to the nerve is occurring due to inadequate blood flow to the nerve as well as pressure. The caveat here, though, is that if you take the molecule systemically, if you inhale THC, then you're increasing blood flow everywhere. And of course, when you increase blood flow everywhere, your blood pressure drops. And so if your blood pressure drops, the actual perfusion pressure of the optic nerve or the eye is decreased because you still have that pressure inside the eye, but now there's less pressure gradient to actually push the blood to the structures. And so lowering your blood pressure is really not a great thing in glaucoma, and therefore to use this medication to enhance blood flow may well be entirely counteracted by the fact that it's going to generally lower your blood pressure. However, if the medication was just exposed to the eye and you did not have a drop in blood pressure, then it's possible that perhaps the cannabinoid could enhance optic nerve perfusion rather than actually decrease it when you take it systemically. Okay, we are making good progress here. I guess the question that everyone had wanted to ask before the show is how do I obtain it? So I obviously you've heard what I've said so far. Look, I don't advocate smoking marijuana or taking cannabis as a glaucoma treatment. At this point, it just doesn't make sense. If your pressure is that uncontrolled, or there are so many better pathways to control pressure, either with medications or with surgery, that it doesn't make any plausible sense as to why you would pursue glaucoma, why you would pursue marijuana for glaucoma, unless there was some other desire you had to be on the drug for another purpose. In terms of access to the medication, I haven't researched in great detail how you can obtain it. I know it's actually not that difficult to obtain for a medical doctor. They're just making it easier. I think you will find more and more doctors will be able to access it. Even in the last week, there has been some changes to the ways that doctors can access medical marijuana or medical cannabis for patients. So I'm sure there'll be doctors who near to you who would be able to obtain it. The problem is also that the doctor's going to have to rationalize why they are prescribing the medication. Just looking at the government websites, there is some direction about common reasons or evidence-based reasons to prescribe cannabinoids for a patient. Glaucoma did not appear on that list. Things like seizure disorders and chronic pain are the main things that appear to be spearheaded for this, and so you would need to find a doctor who was willing to prescribe it and was willing to complete paperwork to make a strong case as to why you need it for glaucoma. I'm sure you'll be able to find it if you wish, but I haven't personally pursued this in great detail because I would not be prescribing it for my patients. In terms of those, I guess the other side of the story is those who wish to use it anyway. Are you going to get a pressure reduction from it? You probably are. Odds are you will get a pressure reduction. It's going to be fairly short-lived. This is not going to be the make or break for your glaucoma. The duration is too short, and you would need to be using a lot of it to get sustained pressure reduction. We do know that pressure fluctuation is not a great thing in glaucoma. In fact, it's quite damaging. So having a brief reduction in your pressure is really not going to do a great deal of benefit in the long-term course of your disease, and will probably just expose your nerve to more pressure fluctuation as the medication has onset and offset. So, all right, I think we've covered a lot. Maybe I'll just wrap it up. If you have any final questions, feel free to send them through. I'll just summarize by saying that cannabinoids, yes, they do lower intraocular pressure. Specifically, this appears to be the role of delta-9 THC binding to its cannabinoid 1, CB1 receptor on the eye. The pressure reduction appears in the order of about 30% in most individuals. There'll be a large range. Some people might experience a greater pressure reduction. Other people don't respond at all. The effect is mediated mainly through increasing the outflow, the drainage system from the eye, with a small additional effect on turning the tap down, reducing the amount of fluid that the eye produces. Everyone seems to be of the same opinion that going forward, topical administration with an eye drop is going to be the most likely to come to market, and we just need to package the molecule in a way that can be absorbed through the tear film efficiently. Research is going to be based around synthetics, so shifting away from plant-derived drugs and more to synthetic analogs of cannabinoids that are going to have maximal therapeutic benefits, so maximal pressure lowering with minimal psychoactive effects. And it would be hoped that they could develop a molecule that might have a longer duration of action than 3 to 4 hours, because then we're talking, right? If we can have a medication that works for 12 hours as an eye drop with a new pathway that no other existing medications exploit, then fantastic. Now we really have a product that could be of great benefit. Summarize. Sorry, I'm just reading I'm trying to juggle so many screens here. Just to summarize the limitations. Absorption of topical drops is a problem now. The short duration of effect is a problem. Tolerance is maybe the biggest limiting factor I see that's still an unknown. We need to determine conclusively whether pressure tolerance develops over time, and if so, which individuals that occurs, and whether there are any particular individuals who are more or less likely to develop tachyphylaxis or a wearing off effect of the medication. Okay, I'm going to leave it there. If there's any final questions, I'm happy to take them. Otherwise, I hope you found this discussion useful. I hope it's been a fair, commentary on where we are at with this topic, and I hope it just makes you more informed to make decisions that are best for your health. Feel free to write any questions in the comments below. Happy to answer them as best as I can following this. Keep in mind, I'm subject only to the literature that's available, and there's limited literature. Therefore, I don't have a conclusive answer really for anyone on any particular topic, because we just don't have the available data. However, one of my favorite sayings in medicine is lack of evidence isn't evidence of lack of effect. And so just because something hasn't been studied doesn't mean that it isn't worth pursuing and there isn't potential here. And I hope that the cannabinoid pathway falls in that category, and we will see in our lifetimes a role here. All right, that's it. We're going to wrap it up there. So thanks so much for tuning in. Hope you found that useful, and we'll catch up again for another show in due course.